Okay, so just to put...
Hang on, I'll just introduce you. So, hi everyone, and welcome to the show. Fantastic to have you here with me today. I have Dr. Katherine Sowden with me, who I met recently when I went to Auckland to speak to her gymnastics club. Well, not yours personally, but you sponsored me to come up there and talk to the young ladies there who are doing gymnastics, which was fantastic. But you are also a gynecologist and the clinical lead at Auckland, help me out there, Katherine, again.
Counties Manukau District Health Board. So, Middlemore Hospital.
Middlemore Hospital, and also have a private practice with a colleague, Dr. Lulu Van Eden, that you run as well. So in gynaecology. So today's discussion is going to be all around women's health and what you see as some of the big problems that our society is facing in regards to women's health, and all along that line. So Katherine, welcome to the show. Fantastic to have you.
Lisa, lovely to be here. So I'd like to,
you go for it, because we were already talking prior to this thing. So let's get started.
Well, I'd just like to talk about one of the issues facing us in women's health today. And it's an issue around lifestyle and a normalization of obesity. And essentially we have an obesity epidemic, and it's due to lack of physical activity and poor food choices. And I guess a lack of understanding in the community about what is important with regards to health and movement and the importance that plays in your general well-being. But one of the things that we deal with a lot at Counties Manukau Health is cancer of the lining of the womb, which we call endometrial cancer, and also the stages leading up to that. So women don't suddenly just get endometrial cancer. It's a slowly progressive disorder that starts with a normal endometrium when a woman is younger, and over time that endometrium changes and eventually it turns into a cancer. Now, the leading cause of that is having too much estrogen, and one of the leading causes of having too much estrogen is obesity. So what happens when you are overweight? Your peripheral tissue, or the fatty tissue, leads to a production of more estrogen. So it's not just produced in your ovaries. You can get a conversion of substances in the fat to make estrogen. So you end up in a hyper or too much estrogen state. And what that does is it essentially turns your ovaries off. Wow. And so this is why obesity is related to infertility, because women don't have a normal ovulatory cycle. And it also creates a lot of, it has a lot of effects in the body, and it overstimulates the lining of the womb. And when your ovaries are turned off in this environment, you don't produce your normal hormonal environment. So you don't produce progesterone, which is part of a normal menstrual cycle, which enables ovulation. So what happens with the constant stimulation of the endometrium, you get mutations occurring in that lining. And then over time, if you continue to get that hyperestrogenic environment, those mutations over time can turn into precancerous and cancerous changes. Okay. And that can occur, traditional teaching for us was this was a very slowly progressive disease, and endometrial cancer was something that affected women over 40 or predominantly over 50. But what we're seeing in the population now, which is really concerning, and particularly in the Maori and Pacific population, is we're seeing these changes younger and younger. And we have women under 20 with endometrial cancer, which 20 years ago was unheard of. Yep. So obviously the implications of that are huge, because it's a cancer, and the definitive treatment of cancer is a hysterectomy where you remove the womb. So this takes away a woman's choice for reproduction. The implications are enormous. They then become heavily involved in the medical system, where they're subject to constant follow-up, constant intervention at huge cost to them personally and at huge cost to the health system. So it is a real worry. And we know, just to put it in perspective, if a woman has a normal BMI, her relative risk of endometrial cancer is 1, okay? And if her BMI is 30 to 35, the relative risk of having an endometrial cancer is 2.5.
Wow.
However, if her BMI is over 40, and we have a large number of women with a BMI over 40 in our society, and it's kind of been normalized to a degree, the relative risk of getting an endometrial cancer is 7.1. So just for people listening to that, that means you are 7.1 times as likely to get an endometrial cancer than someone who has a normal BMI, which is 18.5 to 25. So that is a hugely increased risk. And a lot of these women, young women, are obese from a very early age. And so you can imagine that high estrogen state for all of that time and what it's doing to the endometrium. And that's why we're seeing a lot of women in their 20s now, and they certainly, even if they haven't got the cancer, they've got the precancerous changes. And they're very, when you see them and make this diagnosis, they're very, very alarmed. It's absolutely tragic.
Does this also affect breast cancers as well? Because it's another estrogenic cancer.
So we do know that this also, the obesity and the high estrogen states increase the risk of breast cancer as well.
Wow. So, I studied genetics, as you may well know, and we are always, we're looking at the metabolites of the estrogens and which innate pathway, genetically speaking, a woman takes, whether she's got more of the 2-hydroxy, which is the more protective form of the estrogens, or the 4-hydroxy or 16-alpha, and we have all three, but what she predominantly does that also play into the risk factor? So if we can identify a woman who may have that tendency to make the 4-hydroxy, I've just come off a call with a lady with that particular problem. Is that part of the equation as well? Because then it's the more inflammatory, more quinones and reactive oxygen species and all of that sort of stuff.
Well, it may be, but we don't have any data around that. And that would certainly be something that would be really useful to look at. Yes. But we don't have the data to state that as a fact at this point in time.
Right. Okay.
That I'm aware of.
Okay. Yeah. This is where it's interesting if, because I'm across so many different, I have a shallow knowledge of many different things. It's quite interesting to see and connect the dots sometimes, that because one silo is in here and another silo, is in there. Sometimes you get to see how, would those two dots connect, Yeah,
and it may be so. Are you aware of any evidence around that?
So that the 4-hydroxy, definitely, I'm definitely aware of a lot of clinical data around, and I can't off the top of my head, bring them out, but around the endometrial and the breast cancers, and the increased risk of that. And then if we also look at, for example, hormone replacement therapy or the pill, the contraceptive pill, and how that plays into it. So there's evolving data around that as well, because if you've got the more inflammatory types of estrogens, and then you add in the pill, or later on in life maybe the hormone replacement therapy, what risks? So for example, with the lady that I was just speaking to, has the 4-hydroxy predominantly, and that means it's for her, in combination with some of her other genetic factors in methylation, detoxification, comp genes, all of those types of things, not a great candidate for hormone replacement therapy, because we're going to exponentially increase the risk, if that makes sense. So it'd be good to dig into the weeds, probably off camera, on all of that sort of correlation there. But what you're saying is that obesity is a major factor, and is this because, like, the aromatase gene, the CYP19A1, is this is the one that turns the testosterones into estrogens, if you like. Is that being expressed in fat tissue, and that's why you get a lot more of it when you are?
That's correct. Yeah.
Okay.
So you get that conversion in the peripheral tissue of the androgens to estrogen.
Right. And so the fatty, and this is valid not just for women though, is it? Because if you just look around in the population of our young men who are struggling with obesity, they are also looking more feminized, as gynecomastia and love handles and all of those sorts of things.
Absolutely.
And that this is also playing a role with them in their hormone situation, their hormone household. So what can we do? Obviously we need to lose weight, but where do you think this is stemming from, and why is there a tide of it now? Is it to do with you talked about the Pacific and Maori populations, like genetically, from a genetic, again, standpoint, we have a higher endomorph body type, higher, problems with their amylase genes, their FTO genes, which is their, ability to process fat. They also have a tendency to go after the higher energy, caloric, dense foods than other people. And there's a whole lot of genetic predisposition factors there.
That's right.
So that we need to be doubly careful if we have that, ethnic background. And then there's the food industry. What's your take on what does the food industry play in this?
Oh, well, it's huge, because there's what they call obesogenic food is everywhere. And it's easy and it's available and it's cheap.
This
is part of the problem. And I think we've got no government in New Zealand has the guts to say, actually, this is not okay, because we're creating a public health crisis. And one of the things that they do in some nations overseas is they remove the sales tax of fresh fruit and veggies.
Brilliant.
And, I know in France, for example, they don't put VAT on fruit, vegetables, or baguettes. Well, baguettes is possibly,
Yeah. There may be a cultural thing.
A cultural thing. But, no one has actually been able to stand up and address this at a government level. And I think that does, whatever political spectrum you're from, it's the same. And I think it's unpalatable from a political point of view. However, I think it would be hugely beneficial. If you are a low-income family, how on earth can you afford to fill your trolley with healthy food when it costs 3 times as much as the cheap stuff?
Yep. I'm so in agreement. Yeah.
And I think, we tax cigarettes, we tax alcohol. Why aren't we taxing some of this junk food?
Yep.
It is of no benefit to people whatsoever.
And it's costing the country money, let alone the personal tragic circumstances, which are obviously the first and foremost, but it's actually costing the health system. And it's an avalanche that's coming. I mean, you and I know the statistics on this. There's an avalanche coming as these young people who are now still being able to cope at the moment come through being obese for 30-something years. We are looking down the barrel of a disaster.
Because it's not just cancer, it's things like diabetes, it's things like heart disease, as you know. And I think the current health system, as it is, with the increasing obesity in society, is probably an unsustainable model. And
absolutely.
And we need to do something. And even if it is unpopular, so for example, taxing sugary, high-fat foods and drinks, it's got to be worthwhile.
Yeah, and we have to have these discussions around, because when I go to the supermarket and I want to buy a bag of salad, it's costing me a fortune for a few leafy greens, which should be the basis of my diet, basically, lots of vegetables. And it's much easier for me to go and buy a bag of French fries, that are in the frozen's department. That'll cost me, $2 or $3, and that will cost me $6 for something that's not going to fill me up. So, and the fruits and the so on are hugely expensive. So we have to do something about the basic foodstuffs that are healthy for us. And if we also extrapolate that, I had a nutritionist on just a couple of weeks ago, talking about, preservatives and additives in our food, which are, an unmitigated disaster, and some of the stuff. Yeah, and I was unaware, even to the depth that she was explaining to me, some of what the links that they go to make the food addictive, and so we're all getting addicted. So it's not even all our fault that we're obese.
No, it's not.
This is the hard thing.
Yeah.
People go, well, just, take some personal responsibility. And yes, but there are predispositions, there are genetic sort of factors, there's socioeconomic factors at play, there is cultural factors at play. And then you've got the food industry that is intent on making you eat more of their foods. And the chemicals that are in these foods, if we just take something like MSG or, some of these things make you want to eat everything. And if you have one chip, you cannot eat just one chip. Another. You will eat the packet, and I know that from myself. So I try not to go near the chips aisle, because if I start down that path, I know that I'm lost, because I'm fighting against my ancient DNA, if you like, in this new world with these chemicals that are it's like being exposed to cocaine, you know, and sugar is addictive as cocaine. So if you start down that path, you know, you're in trouble.
Oh, absolutely. And I think in addition to that, there's also been a normalization of a high BMI in a lot of areas of society. It's completely normal to be morbidly obese. And I think part of that is a lack of education as to what the consequences of obesity are. And I think we're very much in medicine ambulance at the bottom of the cliff.
Yes.
And we actually need to put more resource into the community, into prevention.
Oh, amen. I've been preaching that for forever and a day, because and you know, and it's a limited resources, and it's a system that's grown up over decades or hundreds of years actually. And you know, we need a complete paradigm shift to change that and to go into the prevention space. And it doesn't show immediately. I mean, we were talking in the car when we were on the way to our talk, you know, my dream to have this sort of a Warrant of Fitness one-stop shop where you come in once a year, get the complete sets of bloods, your microbiome, your heart checked out, your diabetes, you know, all of these risk factors. We can see if there's any cancers developing. We can see if you're heading towards diabetes. We can catch everything before you fall off the cliff. And then we imagine how much we would save the medical system, but it's not set up that way for a number of reasons. The way, you know, the way it's developed is a disease, you know, control model rather than a prevention model. And then you've got pharmacological sort of pharmaceutical companies who have their own agenda, and it's not always compatible. Well, that's my take, not Catherine's, but that's my take. It's not always compatible with health because there's big money at play here, and we need to at least be having discussions around this. And this is why I was so you know, excited to connect with you, because you're in the system. You see the limitations and the problems, and we all agree there's problems. It's just, how do we attack them and how do we change this paradigm and make it more preventative? And that's what, you know, obviously I'm in that space and trying to help people navigate and be preventative, looking at their genetics, looking at their lifestyle, all of that sort of stuff. But it's not sexy. You know, it's not sexy when I tell somebody they need to maybe eat less of that and more of the good stuff and go for a run and, you know, get some sunshine on their eyes and, you know, all those sorts of things that are lifestyle interventions are really hard sells, because people do like that. Just give me a pill for that.
Oh, there's an expectation, and it's not just give me a pill, it's give me an operation.
Yeah. Oh, yes.
There's people come in and they're not interested in the other stuff. They want an operation because they perceive that's going to fix their problem. But operations don't always fix people's problems. And yes, they have, you know, we can do operations that do amazing things and really cure people of cancer and improve their quality of life. But equally, it shouldn't be the first option. I really believe we've got to look at prevention of these problems, and we are very much focusing at the end of the pathway rather than at the beginning.
Yeah, absolutely. And you're someone who does operations, you know, and there are times when you need that, but it definitely.
And I love doing operations, but it's not always the right thing to do. And a lot of them could be, particularly in these women with these endometrial issues, which is my area. A lot of it can be prevented. Not all of it, of course.
But actually, on that point, can I ask you, because I was just out of my own life, I had fibroids. I've been on the pill for years. I don't know whether that contributed to it. I suspect it may have, because I've otherwise got pretty good genetics when it comes to estrogen toxicity and so on, and adenomyosis. And I was told when I had horrific bleeding, too much information for the public, but horrific bleeding, like I'm talking about, like, you know, like entire year of massive blood loss. So I was in and out of hospital getting infusions. I had childbirth like pains as these fibroids tried to birth themselves out of my body, and they were still stuck on the inside, and so it was falling into the cervix. So I was,
that's horrendous.
Horrific, like, you know, like having a baby every week. And I was in and out of hospital, and I was told that if I did not have a hysterectomy, I would die. I was, it was that bad as far as, you know, and the anemia, I could hardly get my head off the pillow at certain times. And then I absolutely had to have a hysterectomy. Now, you know, I'm very stubborn. And I said, no, I am not having a hysterectomy, because we were still trying to have a child at that point, and we are actually going through IVF now. So I was not going to have a hysterectomy. So I actually went after one specialist after the other and looked at what was happening. I had an MRI done, and I worked out that there was one pedunculated fibroid that was the size of a grapefruit, that it had actually fallen into the cervix, and that was what was actually leaving the whole thing open and, you know, causing the most trouble. And so I asked for an operation just on that, and I couldn't get it, and and eventually I you know, I'm very persistent, I got it. A 10-minute operation. Yes. And I did not have to have a whole hysterectomy, which, you know, is a very invasive and very psychologically and physically a major thing to go through. And so I managed to preserve my chance of having a baby. You know, we're going through IVF now.
Fantastic.
Yeah, but only because I'm very bloody stubborn. I went through a year of hell, though, because I wasn't, you know, not prepared to just go and get it whipped out, which was basically the answer. And in my case, I was lucky that I came across this, but I tend to think that, and this is not backed up by any science, but from what I'm seeing is there's so many hysterectomies happening. Are we doing these too often in general? What's your take on that? You know, is this unnecessary?
There's certainly a lot of hysterectomies are warranted, but we're doing a lot for abnormal endometrium. We're doing them a lot for cancer, and at that point we have to do them. But that the progression of the changes could be prevented at an earlier stage, and we know this. For things like fibroids, I think your fibroids, Lisa, were probably bad luck. Some people get them, and there's not a lot, you know, and I don't think that would have been driven by the
pill or anything.
Or the pill, no. But I think we've always got to look at the patient as a whole person. The less invasive cure, the better. And it's very easy just to jump in and do a hysterectomy and say this will fix you. Well, it would fix your bleeding completely, but then it wasn't actually what you needed at the time. And the fact that you did discover there was another option is fantastic. And I think we need to very much individualize care, look at where the woman's at in their life, look at what they want, and try and match the two together. And I think sometimes we don't necessarily do that particularly well as a profession. Particularly in a system like the public system, where you've never met the patient before they come in, and you have to get to know them in a 20-minute time slot, which is really difficult.
Yeah, I can imagine.
And I can imagine people go away with their head spinning with all this information we give them, and probably sometimes do feel backed into a corner because it's too much in too short a time frame. And I guess that's one of the luxuries you have in a private practice, is you do spend more time with these patients, but we have no option in public because we have this massive workload,
a lack of resources,
and a lack of resources. And that's why the more people we can keep out of the hospital, the better, because it means we can deliver quality personalized healthcare to the people that need to come through.
And it also means that the more we go into our own research and go and try and understand what's happening to our bodies, you know, and there are pitfalls in that, as we all know, and it depends on your ability to research. And,
that's
you know,
right. Because not all the information out there is correct.
No, and you need to know where you're getting your sources from. And okay, I'm a researcher. I know what I'm looking at. Not everybody will know what they're looking at, and nor should they have to, you know.
Right.
But it's still the more you can educate yourself, the better, so that when you get that 20 minutes in the public system, you've got the questions to ask. You know what you're going in for. I do sometimes think we spend more time researching the car we want to buy or the trip that we want to take than we do about our own health, because we've outsourced it. In our heads, we're told that the doctor will take care of it, and you just go to them and they should know everything to do. And that's just not reality.
That's not,
and they have limited resources and limited time and limited ability to stay up with the latest stuff, because, you know, like, how do you do that on top of that and that and that? You know, you're only human. So that's where I see, like, this is where we can be proactive as people and go, okay, I'm going to research this. I'm going to look into that, and I'm going to go and I'll have my questions ready. and then I'll analyze, and I might go and get a second opinion, or I might go and make these, because these are major decisions for women. Huge
decisions.
Yeah.
People don't understand too that, again, the safety of an operation is, there's risks with every operation, and those risks increase with obesity. So again, it's coming back to obesity. For example, we know that if you have a high BMI, you've got an increased risk of a wound infection, you've got an increased risk of bleeding, and you've increased risk of multiple complications, including when you do a hysterectomy, you can damage other organs inside the body, like the bladder, the bowel, or the ureter that goes from the kidney to the bladder. Wow. And all of those things, because the operation is much more difficult in an obese patient. And the other thing is, this is also the ability to be able to do surgery for the number of women on the waiting list is also impacted by obesity. Because, for example, if you have a normal BMI woman, you should be able to do a hysterectomy in an hour.
Oh, wow.
You have a morbidly obese woman, sometimes these operations can take 4 or 5 hours. So you can imagine what that is doing to our ability to be able to offer care and process the number of women we need to be able to process.
Wow, I had no idea that was the case.
But I think people don't appreciate that fact. And then we have surgeons that need to take time off because they've got musculoskeletal injuries, because these operations are so technically challenging.
Wow. See, I don't think people understand.
No, I don't think people understand that either.
No, I certainly didn't.
Yeah, people have got no idea. So we can, if we have a morbidly obese patient, sometimes they're the only patient on the operating list. And so you've got all of these people waiting months, even up to over a year for an operation.
Wow.
And so this is another reason why the health system that's increasing obesity and the obesity epidemic is an unsustainable model.
Absolutely. So we really have to get on top of this obesity, because this is not just talking about women's health here. This is talking about cardiovascular health, diabetes, Alzheimer's, all of these things that impact it. My husband's a firefighter, and they've noticed, like in the, like he's been in there for 25 years or 20 years in the fire brigade and 5 in the Air Force. They are constantly now getting called by the ambulance to come to help with hugely morbidly obese people. That the ambulance crews now have to have specially made beds. They need the firemen to come and actually, and it will take 6 to 8 people. They've had to take down bloody walls and houses to get people out. This is getting to the point where it's just tragic for the person, and it's so tragic for the system.
Yeah.
And it's, and the resources just alone in that, that you've got 6 firefighters coming in to help the ambulance staff. That means those firefighters are not available for other things. Those ambulance people are not available for other things in order just to help someone get off the floor. This is the type of thing that they're seeing. And this is where the food industry, I think, really has to take, a really good look at what they're doing, and, why are we allowing some of these things to be promoted? Like we don't have tobacco sponsorship anymore for a reason.
Yeah, that's right.
We shouldn't have some other, and I don't want to pick on any one particular company, but this is a discussion that needs to be in the public forum. And how about we don't let certain things promote in our sport? Because those are what the young people are looking at, their role models doing, drinking, eating certain things, and thinking that's what I want to be. So I'm going to go and do that. Where you draw the line, God knows, I don't, want to get into the weeds on that, but hey, we need this conversation, because it's going to, people are dying earlier, and
absolutely.
We're increasing our lifespan because of the knowledge and the technology and the medical and all of that. But on the other side, we're actually dying earlier because of the diabetes, the Alzheimer's, the cancers, and that connection between cancer and obesity, I don't think many people make.
I don't think they appreciate it either. And I just want to give you another figure about the endometrial cancer to put it in perspective. So there was a study at Middlemore that in 2012, and they looked at the age standardized incidence of endometrial cancer in Pacific Island women in the county's catchment area. So in 1996, the age standardized incidence of endometrial cancer in the New Zealand population was 1.9 per 100,000. In 2012, in the New Zealand population as a whole, it had gone up to 24.2 per 100,000. So that's increased by, a factor of 20. But in the Pacific population in counties, catchment, the age standardized incidence was 46.06 per 100,000. So this is something that I feel really passionate about, that we need to educate young Pacific Island women what is happening in their community. And I think also Pacific Island women are pretty stoical on the whole, and they tend to normalize abnormal uterine bleeding. And I think we need to be out there in schools, GPs need to be telling them it's not normal to bleed so much that you have to wear nappies. You need to have it investigated, because we can, from even from a bottom of the cliff perspective, as us in the hospital, we can give them progesterone, which they're not producing when they make themselves anovulatory with the hyperestrogenic state. And that can reverse these changes when they're in the precancerous state. So we can, even if they do nothing with their weight, which is not the ideal solution, this is ambulance at the bottom of the cliff medicine, but we can prevent them progressing to get an endometrial cancer by giving them progesterone. And so I think early intervention is critical.
And will would that help also with their fertility and all of that sort of stuff as well?
Well, you're very unlikely to have a baby if you've got an abnormal endometrium. So you need to normalize it. And because we struggle with the weight loss issue, we can give progesterone. And so we are normalizing some young women's endometriums, and they are able, after a period of time, to stop that progesterone and try and get pregnant with some success. There have been some studies that have shown, even with an early endometrial cancer, once you start treating that endometrium with progesterone, that you can get pregnant.
Wow.
Ultimately, though, unless they lose weight and change their lifestyle, as soon as they had the baby or stop taking that progesterone over time, it's going to come back again. The only real way to get a definitive treatment of that abnormal endometrium is either remove the risk factor, which is lose weight, or in the end they do need a hysterectomy.
Wow. And so are you seeing across the board falling fertility rates?
Absolutely, in young obese women.
Wow. And this is a huge portion, not just with the Pacific Island and Maori population, but everybody.
Absolutely.
Like on average, our BMIs are just going through the roof, aren't they?
That's correct. Well, I mean, I've got some, even back in 2013, there was only 34% of the population was a healthy weight in a normal BMI. And I suspect when the more figures that are coming up from the Ministry of Health will show that over time, that's just going up exponentially.
Okay, so this is not just an aesthetics thing, and this is not just you want to look good on the beach. No. This is a
public health crisis.
Yeah, and you're ringing the alarm bells here, and this is really, really good. Can you explain? Like, I've studied a little bit on the metabolic approach to cancer. So this is what we're talking about here, basically, isn't it? The metabolic approach to cancer. Well, it's a bit more involved in that, and I'm certainly no expert on it. But it's basically if you've got cancer, starving the cancer growth through not having high carb diets, but having a more sort of a fats and protein based diet, and not having these, does that play a role? Have you researched it all, versus the genetic approach, the chemotherapy approach? Have you had a look at that sort of data at all?
I'm not aware of a lot of data on that. I mean, I think I certainly think it's an area that needs development, and I think it's really important. I mean, at the moment, with the information that we've got, the oncologists do offer the chemotherapy approach or the radiotherapy approach, or we offer the surgical approach as a first line, because that's what we're familiar with the data. But I'm not saying it's necessarily the be all and end all, and I think there's a lot more we can learn about that. But I think often once you have that cancer, it's much more difficult to reverse a cancer once it's occurred than preventing it in the first instance. And I think that's really where we've got to focus, is looking at the lifestyles to prevent these things occurring, because they don't happen overnight. They are generally a slow progression that we're not aware of until we have a cancer. But it's been, you have those pre-malignant states that slowly develop for a long time.
So I think, what we're doing here at least is initiating the thought in people's heads that being obese is increasing your risk of cancer, the endometrial cancers and breast cancer, Is it also, are you aware that it's other cancers as well, or is it just these ones?
Oh, no, I think it is. There are other cancers. I mean, I don't have the data behind a lot of the other ones, but off the top of my head, breast is not my specialist area, but I think from obesity, you're increasing your relative risk of breast cancer by approximately 3 times. But, I could be corrected by the breast surgeons on that. But it's certainly, we know it plays a part, because the estrogen results in a proliferation of breast tissue. And the more you get that proliferation, the more every time you have cellular changes, you increase that risk of a mutation occurring. And then, of course, we do know that there are the genetic cancers like the BRCA, which increases the risk of breast and ovary, that certainly contribute, and the Lynch syndrome, which is a genetic, with you have bowel and endometrial, and so there are those factors. So some people are at a genetically higher risk of getting a cancer. And even if they have an absolutely pristine lifestyle with a perfect diet, some of them with their genetics will get a cancer. So not all cancers are preventable, but we know that there are, particularly with these estrogen dependent cancers, we can significantly reduce the number of women with cancer by correcting the lifestyle.
Brilliant. And if we just flip the conversation just a little bit and go in the direction of general health for women's health, and what would you like to see young women getting access to education around their whole reproductive cycle and how it all works? Because when I went to school, we were told how to use pads and tampons, and that was about it. Like nobody told me, hey, your estrogens go up in this and the follicular phase and then the luteal phase, and none of that was ever. And if I talk to a lot of my girlfriends, they still don't know the basics.
Yeah, I think the basic knowledge is very poor, and I think we do need better education. And I mean, a logical place to do that is at school. And I don't think that exists. And I know my daughters at school, what they got taught was very, very basic. And they got taught nothing about, because it's also, it's seen as politically incorrect to discuss obesity, but it's not politically incorrect. It's factual, and it's a crisis. Yeah. And we need to stop pussyfooting around it. And I think that young women need to be given the facts about their reproduction, that being overweight will increase their likelihood of being infertile. It will increase their risk of certain cancers. It will increase the risk of diabetes and dementia and heart disease and all of these things. And
absolutely. And I think, like not being like, this is not about not accepting different people in our society and not being inclusive. And that's not the issue, what we're talking about. This is straight. These are the facts on the medical side. This is not healthy to be this way. And therefore, we need to give people the education and the support around changing the behaviors. And we're not saying this is people's fault that they're there. Because God knows that the food industry and just the way our advertising is set up, and that the food is on every street corner, and our ancient DNA. We've come from cavemen. I talk about this all the time. Our DNA hasn't kept up with the pace of change in our environment, right from things from like electric light to the blue lights that we're getting exposed to at night time, to the food that's available 24/7, where it used to be you had to get up, go out and hunt or gather or do something in order to get breakfast. It wasn't. So you were moving all day outside in nature. And when you start to adopt some of those lifestyle changes within the realms of what's possible for you, but that means for me, if I'm stuck on the computer all day, I change between a standing desk and a sitting desk. In between, I'm doing press-ups and sit-ups, and I'm going for a walk, so I'm getting sunshine in the early morning. All of these tiny little ritualized habits that I've developed in order to keep myself sane and to keep myself relatively healthy, and to be proactive in that space. So I think, that's the discussion that we need to be having more.
Yeah, I think so. And there's very little resource. So the health system as it is a vast amount of the health dollar is spent in the final years of someone's life, and very little resource is put into patients in the early years, and particularly in the community, because of the way our model has developed. And something you just touched on then, Lisa, that's really important is also to keep you sane. Well, mental health is just a huge part of someone's well-being. And
absolutely,
the diet and the exercise and the movement is hugely important to that. And also, we've learned in the last few years that a large amount of serotonin is produced in the gut. And if you are eating a sort of an obesogenic, horrible fast food diet, it affects your production of serotonin, which again affects your mental health.
Your depression and all of that sort of stuff.
That's right. And that then affects, you know, if you're depressed, you're less likely to go and choose healthy food. And so it's a vicious cycle.
Yeah.
I think we've also become very siloed in our healthcare model, and this is where the importance of GPs and people in the community is. We need to look at people as a whole, and you know, if you look at one isolated area like we do in hospitals, and we're all sort of super specialized in one little thing, we're not good at actually looking at the whole person because we have such a short time frame to see those patients. So this is a real important role of GPs and other people working in the community.
And that's it. And this is where I see the greatest growth happening and the greatest development happening is with, you know, people like what I do and health coaches and people that are lifestyle coaches and things that can actually, because we just don't have enough doctors and we just don't have enough money in the system. And this is a way that we can bring in allied health professionals, if you like, to actually give people the time of day and actually go through different testing regimes. And everyone has their specialty, you know, not mine are, but you know, I will go to my chiropractor, my naturopath, my herbalist, whatever, you know, area, and all of these things, these people can help in this conversation of being in that preventative space so that you don't even get to the hospitals, hopefully, ever.
Yeah.
You know, like that's my goal, to stay out of the hospital.
It should be everyone's goal.
Yeah, none of us want to go there.
Come to hospital unless you have to.
Yeah, and you know, that's like with the exercise and the hard parts of all of that, and people, I don't want to, it's not pleasant, why should I do it? It's like, I tell you, as someone who's rehabilitated someone from a massive aneurysm and stroke, that path back is horrific, way more unpleasant than going to the gym, going for a walk, going and doing those preventative things and eating nicely than trying to rehabilitate somebody.
Yeah, absolutely. And I'm sure, and you can speak to that from your own experience.
Very, very, very much so. Yeah. So I'm in that space.
Yeah.
Catherine, Dr. Katherine Sowden, you've been absolutely wonderful today. Thank you for sharing your insights and being so candid and open and having these conversations, because only when we actually get to talk to doctors, talk to medical professionals, the people in the public health, and open up these conversations can we get some good positive change. And it's not a us versus them. I don't ever want to be in the us versus them space, because it has to be a collaborative effort if we're going to improve the health of our nation and our world, you know. So fantastic to have had you on the show today. Thanks.
Oh, thank you very much for the opportunity to speak, Lisa. It was been a pleasure to meet you and a pleasure to chat again today. And I hope that it can help raise awareness of the issues surrounding women's health and what we can do. And it's been an absolute pleasure. Thank you.
And whereabouts, Catherine, if someone wants to reach out to you, are they allowed to? And how would they do that? Or even for your private practice, where would they find you?
So they can find me at www.aucklandwomen's.gynaecology.co.nz.
Okay, aucklandwomen's.gynaecology.co.nz. I'll put that in the show notes.
Yeah, and I am through Counties Manukau. It's a little bit more difficult to reach me that way.
Yes, of course.
If people want to reach me through Auckland Women's Gynaecology, then I can point them in the right direction if they want to come through the public system.
Brilliant. Absolutely wonderful. Thank you so much for talking to us today, Catherine.
It's a pleasure. Thank you, Lisa.